Hi everyone, good morning and welcome you all for another wonderful session today. Hope you all are preparing for another wonderful winter in UAE, and I believe you all are already taking the flu vaccination. Right, so DOH is giving vaccination and also many free vaccination here in Abu Dhabi in certain hospitals. I hope you are all are utilizing those options available here in UAE. And coming to the today's topic, as you all, I think you would have checked all your emails, right? So the today's topic is ICD 10 CM 2026 updates, insights, and impact. Actually, since ICD 10 CM codes are published every year in the month of October, and most of our members will be preparing for their exams, right? So hence we felt that it is the right time to have such a topic in this month, so that at the beginning of the updated year, it will be helpful for all our members. So I will, when it comes to the topic, we shortlisted Kanchana as our speaker, right? And she is not a new face to our Abu Dhabi chapter as well. Coming to her experience, she's already having 15 years of experience in the field of medical coding, and she is holding a lot of certifications, including CIC, CCS, CRC, and CDIP. Also, she is an AHIMA certified ICD 10 CM and PCS trainer, and currently she is working as a training and quality manager in one of the leading company in India. So, on behalf of all of you, I would like to welcome Kanchana. And Kanchana, the stage is yours. Please proceed.
Thank you very much, sir. So, good morning, everyone. As rightly told, today's our topic is a very impactful topic, that is ICD 10 CM 2026 updates, insights, and impact. A little background on the title is that not only this presentation is focused on updates alone, like having the information, but what behind the update it is, meaning that also we are going to explore, and its impact when it comes to as a coder. So today's objectives. So today's our objectives is to identify and interpret the key ICD 10 CM 2026 code changes, where we will be reviewing the newly added, revised, and deleted codes, and also its clinical relevance. And the next thing what we will be aiming at is to understand what all are the audit risks it has been linked to on on all these changes. And we also will strengthen our decision making when there is an ambiguous scenarios. We'll see a few scenarios as well in our presentation. So Center for Medicare and Medicaid Services, that is our CMS, have released 2026 updates, and which is valid from October 1st, 2025 to September 30, 2026. So you can see that there is a huge number of new codes added this year when we compare to 2025. In 2025, it was 252 codes, wherein it is 487 codes which have been added newly in 2026. So this looks to be daunting, but I'm very sure that you all will comfortably learn all these new codes, because most of them are related to the expansions due to the inclusion of new sites and the seventh characters, and also the specificity being changed to more specified, unspecified changed to more specified codes. So this slide summarizes about in which chapter how many changes are being done. Here we see that a lot of changes had happened in the injury, poisoning, and center other consequences of certain other consequences of external causes chapter, where 213 codes were newly added. And following to that, the skin and subcutaneous tissue 116 been added, and also a lot of changes in the congenital and as well as endocrine chapters. And also external cause and morbidity also has 20 and factors influencing 26. So this itself says that where you can find the changes. It is all about laterality and a specificity, site specificity. But there is definitely some inputs from this presentation which we have to remember while coding. So that is what we are going to focus and we are going to learn in this presentation. So coming to the conventions, let us start with the guidelines and then move on to the chapters, what is really important as a coder to learn and understand from these changes. So to start with conventions, there is one important change in the conventions, that is on the commas. So IA7 commas have now a different meanings based on the context of its alphabetic index. This is what is a change which they have brought in conventions, where they are detailing, they are providing a detailed information. What is the purpose of the comma? The comma is used for alternative verbiage in some circumstances, and modifier like essential or non-essential, or an alternative term as well. So the comma have now different meanings as per the code, which is that you are leading. And you all will definitely agree with me that convention have a huge impact on our code selection, which may lead us to entirely a different code if we are missing on the conventions. And to just give you a little more information with an example on this commas, how and what is that they are talking about in the alphabetic index. You can see the first snip here with the cardiac arrest highlighted, where here the comma indicates additional information about the complication which we are searching. So if we are searching arrest and cardiac complication and abortion, it says that C abortion, a comma is applied there, and by type, again, a comma is applied, and a complication by comma is applied, and cardiac arrest. Here, it is not an alternative verbiage nor a non-essential verbiage. This is a guidance given to the coders to appropriately lead to the code where the abortion should be the search point, and the next subcategory to be checked is by type and complication, and then go ahead with cardiac arrest. I'm coming to the next snip, which is regarding I25.9, which has been highlighted here. Myocardium, myocardial. Yeah, very evidently it is an alternative verbiage. So here a comma has been applied in that meaning. And when it comes to lymph, lymphatic channel, here the alternative term and also is being applied in this sense of identifying this comma applies if your document talks about lymph and lymphatic channel. Still, this goes with the same code. So the comma have brought in a lot of information, and it might be initially confusing, but if you are leading according to the instruction provided in the alphabetic index, I'm very sure we will be led very appropriate to the appropriate codes. So this is about the convention change, and didn't see much convention changes except for commas. We'll go to the next one. So the next changes on the exception on firearm injury intent. And this snip here should remind you all what we are talking about on IB14, where we have an exception list available, where this can be considered from a clinician note, and a provider is not necessary to provide this information. So we have an independence as an coder to select these codes from a clinician note, wherein we are every time advised to pick the codes only from a confirmed diagnosis by a provider. This is an exception list. So one thing added for 2026 in this list is firearm injury intent. So what does that mean? I have a scenario here placed for your understanding. We can see a progress note, a ED physician note being mentioned here, where the chief complaint talks about the gunshot wound to the left thigh and history of present illness, entry wound noted on the medial aspect of left thigh, and all the other details are there. Denies any suicidal and assaultive intent is being specified, but still the information from the physician is lacking what had happened really. And the physical examination is there just to bring the sample to a live picture. A physical examination also is not giving a clear information about what was the intent of the firearm injury. It's talking about the entry wound, exit wound, and swelling, tenderness, and what are the limitation due to the wound, and also imaging is there, where non-displaced fracture has been documented, and assessment and plan also talks about the wound, but nothing regarding the what happened to that firearm injury, what was the intent. But unlike in the nursing note, which has been pasted next to the progress note, patient arrived via ambulance after sustaining a gunshot wound to the upper left thigh. He was cleaning a loaded handgun when it accidentally discharged. Here comes our intent. What had happened? It was an accidental discharge when he was cleaning the loaded handgun. So here the intent is very clear, but it has been available in the nursing note. Are we supposed to take this intent and code it to the specific accidental discharge from other firearm initial encounter? The answer is yes, because of this change in the 2026 guideline. So the firearm injury intent can be picked up from the clinician notes, and for the example, here the nursing note. So let us go to the next guideline. So a general guideline which has been explained, and that is on multiple site coding. So the classification defines multiple as involving two or more sites. That's well understood. And so what is the change they are bringing here? So how to use the multiple site code is what they are explaining with this guideline. And the guideline clearly states that when a specific site is being documented, please go with the specific site coding. And if the specific site is not being documented, and that is when we have to go ahead and code for multiple site, if in case only multiple site is being specified by the physician. And again, an example. So in scenario 1, the patient is diagnosed with osteoarthritis of both knees and the right hip. The site is very evident and it is clearly documented. So definitely as a coder, I go and code for bilateral primary osteoarthritis of knees, and as bilateral, both knees are specified, and unilateral primary osteoarthritis right hip is coded. And this because the specificity is clearly being specified. Wherein, when a provider documents patient diagnosed in the scenario 2, wherein the provider have documented patient diagnosed with osteoarthritis of multiple joints. The documentation itself says multiple joints, and there is no specificity available. He is not talking whether it is a knee, hip, toe. He is not mentioning it. And in this case, we have a new entry and a new guideline to say that please go ahead and code it to multiple joints, unlike what we used to do with this coding is unspecified code. So please don't go with unspecified code. Please go with multiple sites code, which is available now. And that also adds up to the count of our new changes. So this is about the multiple versus specified site being documented. And a very important caution here, please don't go for unspecified code or other specified code. And we as a coder are allowed to take multiple joins code or multiple site code. So that's about the coding guidelines on the multiple site coding. And the next one, we are coming to the chapter specific guidelines. And we'll start with certain infectious and parasitic diseases. And throughout this presentation, I ensured that we are discussing the most important details of where our coding would be impacted and what is the audit sensitivity highlights we have to be very aware of as an coder. So in the first chapter, there are few organisms which are being added. And every year we have this saying that a lot of organisms are being added. And to this list, Demodox mites is the new infection which has been added. And the next one is acariasis. Uh, Please excuse me if I am pronouncing it incorrectly. And this has been added to the list, and as well as Shiga toxic producing E. coli is being added, and which is again specified into a subcategory with other specific. And in this new addition codes, we as a coder should be very clear about a few things. In that is when a Demodox coding is being done, there will be definitely a denial trigger because it is an organism, and the demand for the coding of the symptoms or the clinical significance because of the Demodox should be done. So this is an important audit sensitivity I wanted to bring today in this presentation for all our coders. And the next one is about the Shiga toxic producing E. coli. And let us all not be confused with E. coli. And E. coli is everywhere in our charts. That doesn't mean it is a Shiga toxic producing E. coli. Please be cautious to check your documents to find a precise strain documented while coding. And this is another interesting, excludes instruction which has been added to the to this chapter, which I thought it is important to bring to your attention about the ascites, because ascites has a lot of impact on our billings. So under chronic viral hepatitis, there is now a new instruction where it advises use additional code for ascites. This was not existing before. So with this, they have created an opportunity for the coders to check when there is a chronic viral hepatitis documented. Please go ahead and check for the ascites. And if at all you find an ascites, you can go and do a dual coding. That is one code for chronic viral hepatitis and another code for ascites. And just to emphasize this point, ascites is a CC condition if you are coding for an MSDRG, and this will definitely impact our billing in either ways. So this is about the infection and parasitic disease, and we have more to discuss on this chapter. That is a huge change and information on HIV coding. Though the coding guidelines seem to be very simple, they have brought it detailed in each step of the guideline, and every point describes it again and again. So what is it telling? So the selection and sequencing of HIV codes in the certain infectious and parasitic diseases talks about how to code AIDS and when to code HIV infection, that is B20 and Z21. So So whenever there is a documentation very clearly specifying AIDS or HIV diseases, or if the patient is being treated with the HIV related illness and your document clearly states that HIV have progressed to a state where it has been showing a symptom that is a relative illness, that is when we have to go code ahead B20, as the HIV infection itself states that it is an asymptomatic human immunodeficiency virus. We have no opportunity to code Z21 once the B20 is being established, that is, the disease state is established in a patient. So I want you all to focus on the point D, patient newly diagnosed with HIV diseases, whether the patient is newly diagnosed or has had previous admissions and encounters for HIV conditions is irrelevant to sequencing decision. What do they mean by this? So they mean to say that if a patient is an HIV disease or AIDS patient, he can never be into a, you know, be coded as an Z21 asymptomatic asymptomatic human immunodeficiency virus. Infectious status cannot be coded to that particular patient. So once established as an AIDS patient, forever he is going to be an AIDS patient, and we cannot, you know, code Z21 asymptomatic ever back in his life. So that is a glimpse about a short form of this whole guidelines, which has been impacting each point in our guideline, if you see here. So, and inconclusive HIV serology, we all know that there is no much changes to this guideline, just the verbiages have been changed in this, and we still code it as R75. And when we talk about the previous diagnosed HIV related illness, this guidelines still talk about what I have mentioned, that the patient once been diagnosed with a HIV related illness should never be coded back to Z21, that is an infectious status. When we come to the pregnancy, childbirth, and puerperium coding, HIV infection, we know the golden rule for chapter 15. That is, we have to code the O series code as primary. So we should stick with the same guideline, no change there. 0987 goes as a primary or principal diagnosis. And definitely we have to look into the document to code appropriately B20 or Z21. Accordingly, we sequence it accordingly. But the primary stays 09871. I'm sorry, 7. And the encounter for HIV testing, this has only verbiage changes, and still that is Z11.4. And the sign and symptom again been emphasized, and encounter for tests, which is Z11.4, the same. And whenever the test is the reason for the admission, we code it to encounter for test, which is Z11.4. And we also ensure that we are coding and counseling code additionally, Z71 and 7, because for sure you'll find it in the document that counseling happening for the AIDS patient. And when a patient is presented for following regarding a HIV test, but the test outcome is negative, we assign Z71 7, and that is the counseling code. So that's about the HIV B20 and Z21 coding. And here, this slide summarizes about the medication, antiretroviral medication, how to code and when to code. And we also have this K, encounter for HIV prophylaxis measures. This is a very interesting inclusion for our HIV coding. So the antiretroviral medication has no changes. Who have a very good command on the guidelines know what I'm talking about, that there is no change with these guidelines. We are still going to code the antiretroviral medication along with B20 and Z21, that is the asymptomatic human immunodeficiency virus, and be it HIV related illness. We still have an opportunity to code for a long term antiretroviral medication. And as I told, this K encounter for HIV prophylaxis measures is a new one. And when a patient is presented for the administration of pre-exposure prophylaxis medication, we have a code introduced, that is Z2981, encounter for HIV pre-exposure prophylaxis code. And the this code is to be coded. And addition to this, the intent to prevent the infection, what is the intent, that also to be coded. And the high risk, why this is to be, why this pre-exposure prophylaxis is to be coded, that high risk also should be coded as an additional code. That is what about this encounter for HIV prophylaxis measures. So 3 opportunities here to code. One code to say that there was a medication given, that is prophylaxis given, and another one is the intent, and the third one is the high risk. What is the high risk? He is here to get this pre-exposure prophylaxis medication. All these 3 to be coded according to this guideline. And we are not yet done with this HIV. And this would be the last instruction on HIV. Pretty much no change again, but again, let us just walk again for us to recollect the guideline. And I every time believe that even a tenured coder should go back to the guidelines and have a walk at the guidelines once in a while, to ensure that we are refreshing on our guideline and ensuring we have no deviations. So again, back to our point. So here the anti-neoplastic chemotherapy, immunotherapy, and radiation therapy has been changed, where the verbiage alone is changed and not the intent of this guideline, where we still have an opportunity to code both anti-neoplastic chemotherapy and immunotherapy and radiation therapy. And the sequencing doesn't impact because of which is been given. If all the 3 are given, code all the 3, and either can be sequenced as an encounter of the visit. So that is what has been mentioned in this guideline. And malignancy for which the therapy is being administered is definitely is to be coded as a secondary diagnosis. So when a patient is coming for an encounter for antineoplastic chemotherapy, immunotherapy, radiation therapy, the encounter code goes as a primary listed code and a secondary code for the specific malignancy which the treatment has been done for. If all the 3 are given, all the 3 are coded, and either can be sequenced. And just a caution on the implantation of the radioactive elements. So we are not supposed to code this as encounter for antineoplastic chemotherapy, immunotherapy, or radiation therapy. And of course, not a radiation therapy. It is a radioactive implantation. So please be very cautious about not putting that Z510 code when you see an radioactive element being implanted, because the meaning is not the same. And just to recollect what we have read through this chapter, so B20 versus Z21 clarification we had to use the AIDS, HIV disease, and any HIV-related illnesses to be documented as B20. And these are the common HIV-related diseases which we see in the documents. And you see Kaposis sarcoma, very common with the HIV patients, and cryptococcal meningitis. And this is not the only 2 which I just mentioned here, but there is a whole list of diseases which commonly occur with HIV diseases, which is very easily available in CMS. And advisable to take a look at that list. And Z21 use only when the HIV is positive, HIV test positive, and without any signs, symptoms, or any illnesses. And HIV in pregnancy, childbirth, and puerperium, code only 0987X first, and then goes your AIDS and HIV codes. And new inclusion, pre-exposure prophylaxis. Please remember that, which we spoke of just a few slides before. That's a new code which has been introduced on the pre-exposure prophylaxis. So Z2981. And what are the audit sensitivity highlights we have to be aware as a coder when it comes to this certain infectious and parasitic diseases? Please don't exchange Z21 and B21. Don't interchange them. And please be aware that how to code and when to code B20 and Z21, because it's going to be a huge impact on your billing. And coding new and supported and preventive care tracking. This is very important tracking because there is a huge analysis. That is what the CMS has mentioned. There is a huge analysis going to happen on this prophylaxis. So be very cautious to ensure whenever there is an prophylaxis provided to score it while you are coding. And chapter 15, I think we have overemphasized the importance. And I wanted to bring this last point, though it is not a change. I thought it is a good time to discuss about this point as well on the hemolytic uremic syndrome, because this is having an exception. There is no change in 2026 on this guideline, but I just wanted to emphasize this point again because we see a few errors on this coding. Hemolytic uremic syndrome is whenever it is linked with HIV. Ensure that hemolytic uremic syndrome is coded first and the B20 is sequenced the next. Because of the guideline, again, there is a well-established guideline which talks about hemolytic uremic syndrome to be sequenced first and which should be followed by the B20. So just highlighting that guideline. Okay, now we'll just see a small snip of a chart where let us see if you are concentrating with the slides. So here we see that the chief complaint is chest pain radiating to the left arm, onset 2 hours prior to arrival, and present illness talks about patient reporting the substernal chest pain with a diaphoresis and no recent illness or trauma being documented. And in past medical history, AIDS diagnosed 5 years ago is documented. Hypertension, hyperlipidemia is there in the past medical history. And in the assessment and plan, the physician is documenting very clearly acute coronary syndrome. That is the reason for the chest pain. And he is ruled in as CAD, that is coronary artery disease. And he is clearly stating that HIV infection and he is stable with the ART. And continuous current antiretroviral regimen is being done and admit for cardiac monitoring and cardiology consult. This is the case. I'll give a minute and please decide over the AIDS coding, how you will do. Whether you will code it to B20 or whether you will focus on HIV infection and code it to Z21. As per the new guideline and so much emphasis done on each guideline which has been specified with HIV, what is the code you would pick, B20 or Z21? So the answer is, I think most of you would have got it correct. So the primary diagnosis definitely it goes as I-2510, that is CAD, because AIDS was not related to CAD and nothing to do with the B20 or AIDS. So still your primary diagnosis stays as CAD, I-25.10, but it definitely is B20. it's not Z21 because he has been already an AIDS patient and he can never be a Z21 ever in his life again. So be it 5 years, be it 10 years, once an AIDS patient recorded in the document and it is available in your document, ensure that it is coded to B20, though in the assessment and plan, the physician have emphasized it to be HIV infection. And he is also telling there is a long-term use of antiretroviral regimen, still we go with B20. So that brings us to the next our chapter, that is neoplasm. So in neoplasm, a very important change, very less changes though in neoplasm for a change from last year. So in general, we definitely see a lot of changes in a neoplasm in general, but this time we have 4 codes changed in neoplasm. I'm sorry, changed, not changed, included. So there is no change, 1 deleted. So that is the update about the neoplasm. And what is that new introduced cancer is malignant inflammatory neoplasm of breast. So what is this malignant inflammatory neoplasm of breast? This is an invasive breast cancer where the malignant cells get blocked due to lymph vessels and in the skin of the breast, causing a visible inflammation. And that's the reason inflammatory carcinoma of breast. And of course, the codes have included laterality and also an availability of unspecified breast for us to code appropriately. So this is the newly introduced cancer. Please be watchful on finding it in your documents. And the next one is D4811. That is a desmoid tumor, which we usually used to end up coding as unspecified soft tissue neoplasm, which whenever there is an aggressive fibromatosis, we end up coding it as unspecified soft tissue neoplasm, but we do have a code very specific to this aggressive fibromatosis, that is a desmoid tumor, D4811. So we need not go for an unspecified code moving forward. And benign neoplasm of a colon, no change here to the code as such, but there is an exclude being changed. That also is an important change as a coder. I believe that you will agree with me that excludes 1, if it is moving to excludes 2, that is a huge change for a coder in his approach. Because when there was an exclude 1, there is no possibility for me to code inflammatory polyp of colon along with a benign neoplasm of colon. But now we have an opportunity because the excludes 1 is changed to excludes 2. So D126, these are the important changes which we definitely have to take a look and implement in our coding. So whenever a benign neoplasm of colon is documented, if you have an inflammatory polyp of colon as per the excludes 2 instruction, if both are treated separately and taken into attention by your physician, and which is very evident in your document, comfortably we can go ahead and code both the codes because of this excludes 2. And pretty much that is what is being changed with the neoplasm. And the audit sensitivity highlights with this chapter is typically on breast cancers, which what I would like to talk on the inflammatory carcinoma of breast. The sign and symptoms of this is not lump. That's a huge takeaway from this chapter. So please don't look for only lump moving forward when you see any samples being collected from the breast and you are finding your document is marching towards cancer or protocol is marching towards cancer. Check for redness, swelling, warmth, and also orange textures in your document, because the sign and symptom of inflammatory carcinoma is quite different to other carcinoma of breast. And please don't have an habit to stick with lump. So that would be a pitfall for us as a coder. So please be cautious about the sign and symptoms. while checking for the breast cancers. And another important thing is the inflammatory carcinoma of breast cannot be documented or cannot appear in the mammogram. So we have to check for the biopsies, confirmations when it comes to inflammatory carcinomas. So don't skip your pathology reports. Ensure that whenever you are checking for the documents, ensure that you are checking for the pathology reports accordingly and coding to the highest specificity available. So don't be misled with the mammograms. Check the biopsies because inflammatory carcinoma cannot be seen in mammograms and it would be evident with the biopsy. And the documentation must specify inflammatory. Just because of signs and symptoms, just because biopsies, don't go ahead. Please check for inflammatory subtypes mentioned and laterality being specified in your documents. So pretty much these are the audit sensitivity highlights from the neoplasm where we may have a documentation pitfalls and misunderstandings. Let's go to the next chapter, that is disease of blood and blood forming organs. Sorry. And the new category included in this blood and blood forming organs is leukocyte adhesion deficiency. This is a rare genetic immunodeficiency, and where the white blood cells fail to adhere to the blood vessel walls and migrate to infectious sites due to defective adhesion molecule. So as genetic immunodeficiency condition, definitely it has type 1, type 2, and we have to be looking out for this diagnosis. Please familiarize these terms because these are new introduced conditions, and that's the whole purpose of this presentation, familiarizing the guidelines and familiarizing the new conditions which have been introduced. So leukocyte adhesion deficiency, so please be aware of this condition. And in nutritional anemia, there is no change with the codes, but again, excludes 1 and 2. Yes, excludes 1 is changed to excludes 2, giving an opportunity for the nutritional anemias and deficiencies to be coded together. So if you see, I have given a snip from the changes. So excludes 1 is deleted for nutritional deficiency without anemia, copper deficiency, molybdenum deficiency, and your zinc deficiency. So with this excludes 1 deleted and included it to be excludes 2, we all know we have an opportunity to code both if, again, both are treated differently and recognized by the physician in the document as a separate conditions. So whenever there is an anemia documented along with that nutritional deficiencies documented, let us all be watchful to find if both are treated separately and coded appropriately. So coming to blood and blood forming organs audit sensitivity highlights, please look out for a lady and ensure the subtype is coded appropriately because the impact of the genetical tracking which is our priority as well along with the billing. So we have to ensure that that has been coded as well appropriately. So the type 1, type 2, all these details should be coded appropriately. Ensure anemia is explicitly documented and don't assign D538 based on deficiency alone. You have much more specificities available in this aspect. And if both anemia and deficiency are present, there is definitely a opportunity to code both. And please ensure that you're checking that in the document that both are given attention. And coding this will definitely reflect a full clinical picture of your patient. And avoid any undercoding by omitting the deficiencies. And this is an important takeaway from this blood and blood forming organs, nothing to do with the guidelines, but I thought this is the right time to bring up this point of Low zinc never means zinc deficiency. This is a vague term. Whenever the low zinc, low copper, or any other verbiages are being documented, please don't go ahead and code it to deficiency, please. Code it to only whatever is available in the document. Low zinc doesn't lead us anywhere in the alphabetic index. So ensure that you are querying for the document and getting that exact term and appropriately, which can lead us to the diagnosis. So that's about the third chapter. And fourth chapter has a huge buzz about this remission. So everywhere they are talking about E11A, and definitely a very good addition to our changes on the type 2 diabetic mellitus in remission code. What does this E11A mean? That is the diabetic 2 type 2 diabetic mellitus without complication in remission. And this should be assigned only when the physician is documenting it very clearly. What does in general remission means? Remission means that a disease is no longer active, but disease is there. Yes, the disease is there, but is it active? No, it is not active. That is what is the picture we are creating behind the type 2 diabetes mellitus when we are coding it to remission. So the guideline, it is pretty interesting for me to find this resolved being clearly mentioned within the guideline, saying that the resolved is not a synonym for remission, because definitely they had they had predicted there would be an confusion between resolved and remission. That is the reason the CMS have clarified that resolved is not equivalent term to remission. So let us all have this clear understanding when to code type 2 diabetes mellitus in remission. I'm just moving to the tips for E11A. So diabetes should be documented as remission. Very important takeaway from the remission, and very easy to avoid error point here. Please stick with the documentation. If remission is documented, code it to remission. And that's so simple. Don't go with a resolved, controlled. All these terms doesn't mean remission. I wanted to emphasize this again and again. Please ensure remission is documented and don't go ahead with any equivalent terms, resolved, controlled, or anything similar to it. Provider must document it. And one more important tip is the provider must document remission, not the nurse, because we generally see in the document that nurse clearly specify it as remission, relapse. All these terms we generally see in the nurse's note. That is why I wanted to emphasize to you all, ensure that you are verifying your document to absolutely hit that, provider's document to see whether he is specifying remission. Don't go with nurse's note. And if you see any vague, unclear terminologies, of course, please query if that is an option, or ignore coding if the query is not an option for your coding. If you don't have a process of querying, please don't code it. Rather, coding, don't end up coding what is not documented, please. And the next one is no active complication should be there, because if you again revisit the description of E11A in our guideline, it clearly states type 2 diabetes mellitus without complication in remission. Remission itself means the meaning that it is not active, right? So we should find the important things in the document and find that no complication is being attributed to the diabetes, even with conditions. I wanted to specify that, even with conditions where we are defaulting the complications, those conditions also should not be there in the document. If it is there, please go ahead and query. If any complication it is leading, don't code for remission. And that is a very important takeaway. And history of diabetes is not an equivalent term to remission. Always clarify. So these are the important tips I wanted to bring today on this type 2 diabetes mellitus in remission. It is a wonderful code inclusion for our change, because now the physicians will be able to identify who is active, who is controlling, and who is a resolved case, completely a resolved case. So we will be building a very good statistics on utilizing this code which has been included in 2026. So that's about the type 2 diabetes mellitus in remission. And we go to endocrine, nutritional, and metabolic diseases. We have a few important guidelines and codes being added to this category, which need your attention as well. In that, first one is familial hypercholesterolemia. Again, it's a genetic condition that interferes with the removal of LDL, low density lipoproteins from the blood. So the importance of this familial hypocholesterolemia is it causes a risk for heart diseases and myocardial and cerebral infarctions. So pretty much, I'm very sure the physicians will start documenting this, specifically familial hypercholesterolemia, and ensure that you are coding to its complete specificity if available from the document. So you see that familial hypercholesterolemia is further divided into homozygous familial hypercholesterolemia and heterozygous familial heterocholesterolemia and familial hydrocolesterolemia as well. So that's about familial hypercholesterolemia. And the next one is hyperoxaluria. Oxaluria. So what is this hyperoxaluria? So we have heard about this oxalate levels. I'm very sure in your research on the health and health strips, you would have definitely seen something like oxalate levels. So hyperoxaluria is a very important addition to our endocrine, nutrition, and metabolic diseases. This means that excessive amount of oxalate is found in the urine. And oxalate is a natural compound found in most of the foods, like, mostly they talk about tomatoes and brinjals. And and our body also produces the oxalates. And when oxalate levels are too high, eventually that may cause the kidney stones. So just to emphasize the importance of hyperoxaluria. So this is something you will be definitely finding in the documents, because they have further classified this into two, that is primary and secondary. Primary talks about the genetical disorder. The secondary describes about the increased, gastrointestinal disorders, and which is increased ingestion of oxalates. So the primary talks about genetics, and secondary talks about the physiological, occurrence of the hyperoxaluria. So please be informed about the hyperoxaluria and its types and opportunity, and find for it in your document. The next is pyrophosphate metabolism or disorder, a metabolism disorder. And what is this metabolism is all about when the body is not properly regulating the pyrophosphates. This is a molecule which prevents the calcium phosphate deposits in the tissues. So they have classified this further into ENPP1 and ABCCG and CD73 deficiencies. And when I went back and saw what is this genetical and what is this whole description, how it will be documented, I understood that ENPP1 and ABCC6 and all these are the molecules which belong to pyrophosphate. And we can believe that the physician will definitely mention the specificity if he is bringing the pyrophosphate metabolism disorders. So please be watchful on the specificity when it comes to pyrophosphate metabolism disorders, and the deficiency ENPP1, ABCC6, and the CD73 deficiency, if they are occurring, there more further specificity is available. And one more important thing to note is whenever a pyrophosphate metabolism disorders are been occurring, as the deposits are happening in the tissue level, there is a high chance of other associated conditions, which is definitely included in our use additional. So ensure that the heart disease, the heart failure, secondary hypertension has been coded along with the pyrophosphate metabolism disorder. And lipodystrophy is being expanded. The next category is lipodystrophy. And you are well familiar with the lipodystrophy because I remember that it was being included a few years before, but it has been expanded further. So lipodystrophy refers to a group of disorders which impact the adipose tissues and how they are being distributed in the body. So this is having a huge change in the lipodystrophy according to its specificity and location and its relationship with the HIV. So these are the new expansions we have with lipodystrophy. If you are coding for a if you're coding for an hospital which is high with this type of a documentation, please be aware that there is a lot of specificity available with the lipodystrophy. And just as in to close the endocrine, nutritional and metabolic diseases, audit sensitivity again, familial hypercholesterolemia. Please ensure that genetic type is being captured, and you will definitely agree with me. There is a huge impact on the risk adjustments and the treatment justification when it comes to the specificities, and distinguish between the primary and secondary hyperoxaluria, and coder must document lipodystrophy to its highest specified specificity. And when it comes to lipodystrophy with the HIV status, ensure that the sequencing is right. And there is also a drug-related adverse effect being added related to lipodystrophy, and that is T37 series. Just make a note of it. And pyrophosphate metabolism disorder, we have to ensure that the associated conditions are coded. They have not specified the sequence. It is code also instruction. So please decide according to the documentation protocol what is the perfect primary to be listed in your document according to the way the patient had admitted, and what is the focus of treatment, what the physician is taking and considering. All this, it has to taken into consideration before sequencing pyrophosphate metabolism disorder and the associated condition, because there is an instruction code also. We'll go to the next one, multiple sclerosis. Nervous system is all about multiple sclerosis with these changes. So multiple sclerosis phenotype coding has been introduced with the specificity in this edition of 2026. So multiple sclerosis is now no more a single code. Multiple sclerosis have a lot of classification according to its phenotype. And when I went back and saw what is phenotype, phenotype in a simple word, as in how much it is required for me, it is how the disease shows up in the body. So the pattern of symptoms and how the condition behaves, that is the phenotype. So you can see in the table that the multiple sclerosis is divided into relapsing remitting multiple sclerosis, primary progressive, and if you switch to B, active primary progressive, and the C, I mean to say G35, C0, C1, C2, that talks about the secondary progressive. Ideally, it is for me like, it is relapse remitting, primary progressive, and secondary progressive, active or non-active. So these are the specific phenotypes available for you to check in the documents to code it appropriately, the multiple sclerosis. So just to have a little more information on what is relapsing and remitting, it is a flare-up followed by recovery. It is like, a characteristic confused state of a multiple sclerosis. And primary progressive is gradual worsening from the start and no clear relapses identified. And secondary progressive is initially it is relapsing and remitting and course is followed by a gradual decline. So this is the meaning of relapsing remitting, primary progressive, secondary progressive. I wanted to again touch back on the phenotype options available, multiple sclerosis to register form, like relapse remitting multiple sclerosis, primary progressive, secondary progressive, and primary is further divided into active, non-active, and secondary is further divided into active and non-active. And of course, we have G35D, that is multiple sclerosis unspecified. But with so much of specificity, I am very sure as coders, you all will check onto the specificity availability in the documents. And of course, there is two other, which is not related to multiple sclerosis, which has been added, that is apraxia and the L, sorry, LGMD. And what is the LGMD? It is about the limb girdle muscular dystrophy. So we'll talk in a while about it. So this is about apraxia. It is clinical symptoms of neurodegenerative diseases, and the patient may have difficulty in forming sounds, words, and sentences. But it comes with a specificity. Apraxia by itself, it's not having a code. But primary progressive apraxia of speech is having a new code that is G31.87. Please be watchful on this apraxia. This seems to be a little new to our ICD-10-CM, so ensure you are focusing on it. And limb girdle muscular dystrophy affects the skeletal muscle, causing progressive muscle weakness, pains, and atrophy. And maybe you have to be watchful with the limb girdle muscular dystrophy in the patients who are coming with multiple falls and a repeated fall, which we see in the documents most of the time. So you can check if the physician is documenting the limb girdle muscular dystrophy. And again, it is having two options classified, one genetical and another one is other limb girdle muscular dystrophy. And coming to the auditive sensitive highlights about this disease of nervous system, as we were talking about multiple sclerosis, please be aware of the options on the subtype and activity statuses and ensure that it has been coded appropriate to the highest specificity available. Avoid multiple sclerosis G35D unspecified code. When we are having so many specificities, it is fair enough to go ahead and review the document to find the specificity. And when it comes to limb girdle muscular dystrophy, coders must capture the genetic subtype when documented. And apraxia supports precision coding and align with the neuromuscular registry tracking. And this applies to any genetical and any other new codes introduced. Please ensure that you are coding not only for the billing purpose and there is something called as registry tracking for each diseases. And there is an importance for us to capture the genetic subtypes because to serve the registry tracking appropriately. And ensure apraxia is given to its fullest specificity, primary progressive apraxia, and not just apraxia. Speech difficulty will never be occurred to code G3187. So that's about the 6th chapter. We don't have guidelines for chapter 5. So we are just quickly moving. We are already half away. So I am very sure you are attentive here, just checking. And we will just navigate to the next. Please be with me. We are already half away. And thank you for your concentration and hope you are understanding. And please take a note of the questions if you may have. And I'm sure we can have a conversation about the clarifications. And diseases of eye and adnexa. So inflammation of the eyes. And one thing before even starting to talk about this chapter, I wanted to emphasize, if you remember the codes, we had highlighted that eye and adnex have 17 changes. So I'm just emphasizing again the point. It's all about laterality. That 487 was all about laterality, sites, most of the cases, and a few diseases which we have to recollect and remember. So, inflammation of eyelid is being expanded to multiple sites. So laterality is included, and also the site on laterality is included, and unspecified also is available. So when we talk about the code also instruction which is available for inflammation, sir, am I audible now? I'm extremely sorry for the disconnect, sir. I think some internet issue is there. Thank you. Yeah, I did it. So I think you have not missed much on the nervous system, what I was speaking. I'm extremely sorry about the disconnect which had happened, and let us progress. So I and Adnix, there is nothing huge change here. Inflammation of eyes, according to their laterality and specific codes, it has been changed. And of course, with laterality, upper, lower, unspecified, the code number is increased in this inflammation of islets. So please be aware that organism to be coded appropriately when it comes to inflammation of eyes. And I hope you would remember the demodoxamide, which we studied in the first chapter. And one important disease which has been introduced, which I want you all to recollect, is about the thyroid orbitopathy. So this is a new disease which has been included in 2026. And this new code addition brings again a lot of codes with laterality and unspecified. But the important catch here is about the code also. So we have an opportunity to code the important diseases which are associated with the thyroid orbitopathy. And the word itself clearly states that thyroid disease which is causing some eye disease. So thyroid orbitopathy, whenever it is documented, one important catch here is on the relationship. I have given a small snip here on the important things to note when we are reviewing the document. I love to see the document rather than guideline and code. When we are relating with the chart, it gives more information. That is what is very important, and that's a very good way to look into the guidelines and codes. So here comes a patient presented with swelling and lid retraction of the right orbit, and he have a lot of addressing about the eye clinical note. And in assessment is what I want you all to focus. There is a document saying thyroid orbitopathy, right orbit is documented. And autoimmune thyroiditis is being documented. Here, to completely code this chart, we have to ensure that we are coding thyroid or orbitopathy, and that is right orbit, and autoimmune thyroiditis also as an add-on code. Though it is a code also, still we have seen here thyroid was not the reason for his admission. We can clearly see that there was a swelling in his lid and a retraction of the right orbit, and that is the reason he is just coming up for the admission, and a whole evaluation is done in that aspect. So the sequencing goes in that manner, that thyroid orbitopathy is being coded as a primary. So that's about relationships. Just to emphasize that relationship between the disease and especially the eye disease and thyroid is to be established in your documents. And next comes our neovascular. This is again a new disease which has been introduced in 2026. And this means a neovascular secondary glaucoma. And this occurs because of fibrovascular tissue closing the anterior chamber of angle of the eye. To whatever we understand, fibrovascular tissues are being, something to be damaged, and neovascular is a disease which is associated with the glaucoma. And definitely, it also comes in with a lot of laterality information. And when it comes to glaucoma, secondary, primary, and all these details also have included and appropriately classified. So, neovascular, secondary glaucoma, primary glaucoma, all this is what you have to remember while coding the eye specific charts. So the next one is not a code change, but again an excludes change. Retinal coding clarification is provided with excludes note on the retinal detachments and breaks. Very common disease to see. So retinal detachments and breaks are very common. If anybody is coding for ophthalmology hospitals, you will definitely agree with me. Retinal detachments are the top. So retinal detachments, when we are coding, we have now created an opportunity with excludes 2. Before it was excludes 1, which was revised to excludes 2 with peripheral retinal degeneration without break and with break. So this is an important information. Whenever you see retinal detachment along with that peripheral retinal degeneration, ensure you are again walking through the document to find if both are appropriately treated and code both. There is no excludes one moving forward for retinal detachment. So coming to our audit sensitive highlights, inflammation of eyelids, please be aware that there is a huge specificity on laterality and location available. Please ensure that you are, appreciating it from the document and ensuring coding it appropriately. And when it comes to orbital, capturing the orbit laterality and associated thyroid conditions, you have to be very specific about whether it has been related in the document or not. So that's all for the I chapter. And we are almost more than half away now. So disease of circulatory system, a very important change. I'll not say change because change may trigger a question saying that is the relationship been compromised moving forward with hypertension with heart disease? No, there is no change into that understanding, my dear coders. It is like it is going to be the same thing, but only the verbiage is changed and conditions are being included in the guideline. And one important emphasis they have done about the heart disease, how to be considered. That is over here, the difference, the same heart conditions, all the conditions as I specified is being listed, and hypertensions are coded separately if the provider has documented they are unrelated to the hypertension. This is the mostly impacted guideline according to me. This information in the guideline is mostly impacted because of the coding, because the coders miss to see that relationship. So we default the code every time with an default relationship, which is allowed with the guideline. So again, mentioning the point, hypertension with heart diseases is going to be the same. And we are going to see that hypertension it is only that the the guideline specifies that a list of conditions are being included what to be considered. And I want today all our coders here to ensure that we are understanding and appreciating this guide which was already existing, that is hypertension if it has been related to any other conditions. That we have to check before going ahead with the default relationships. So that is the only change I see with the hypertension with heart diseases. And this is a huge change. The Fontaine related circulation is a very interesting change found in this this edition of changes in 2020 2026. So what is this Fontaine related circulation? Sir, as I got disconnected, just a mic check, sir. Am I audible? Thank you, sir. So the Fontaine related circulation is an interesting thing for us to understand. This is a new introduced condition again. So what is a given that it is actually a surgical procedure. A Fontaine circulation is a surgical procedure which is performed on kids most of the time, where one of their ventricles in the heart are not functioning properly. It is a congenital heart defect. So what they do to reroute that blood is to directly route it to the pulmonary artery. So you can see that being emphasized in the image which I have added here. They have rerouted the lower body blood to flow directly into the pulmonary artery. You know that pulmonary artery carries the deoxygenated blood, right, to the lungs. So what happens in this procedure is they wanted to reroute the blood directly to the lung. So they just ignore the presence of the ventricle, or if it is not present, they just take a reroute and route the blood into pulmonary artery from the lower body parts. And this definitely saves the critical situation of the patient. But in long run, it causes relatable diseases. So that is Fontaine associated diseases for which we have now codes to address. So the Fontaine associated liver disease, Fontaine associated lymphatic dysfunction, and other Fontaine associated condition, and Fontaine related unspecified circulation unspecified also is being available for us to further specify this condition. And you can see in the instruction in the table that we have an opportunity to code also the associated conditions along with this Fontaine related circulation diseases. So just audit sensitivity highlight on the circulatory system, confirm the document is having a Fontaine physiology in your document. Maybe he might have a surgical history. You can just go ahead and check with the surgical history, or congenital heart context is being there in the document. You can just check into that and then progress with coding the Fontaine related circulation along with the definitely along with the complications which have occurred due to this Fontaine related circulation. And no big changes in respiratory and digestive. Again, a surprise to us, because mostly respiratory and digestive system gets most of the codes been added. But this time we don't have any code added, but only few excludes one changes, and only 3 changes to be very particular, 2 for respiratory and 1 for digestive. Very meaningful though. So the first one is on the COPD, J44, other chronic obstructive pulmonary diseases. Here, this was excludes 1 where chronic bronchitis and all this chronic tracheitis and all this were listed as excludes 1 when it comes to COPD coding. And it has been moved to excludes 2 now, chronic bronchitis. And all this is been moved to excludes 1. And I'm actually very happy with this change, because this was a long awaited change, which I was, particularly looking for, because there is definitely a treatment specificity difference between COPD and bronchitis. You all will be agreeing with me. So there should be an opportunity for us to code both, because in most of our documents, we see that COPD is taken a specific interest from the physician, as well as the chronic bronchitis. There is no meaning in keeping that, excluded. So happy to see that it has been included into excludes 2 in 2026. So we have a small gate open to check the document if both have given, both the physician is giving the attention and take this opportunity to code both. And the same had happened with the next one, that is J84. I'm talking about the respiratory changes still. Other interstitial pulmonary disease now excludes one is deleted on pulmonary fibrosis, which had occurred due to chemicals and gases, fumes and vapors. So that has been now deleted, and it has been, interestingly, code also has been applied onto it. If applicable, pulmonary fibrosis due to inhalation of chemicals, gases and fumes has been added. And coming to digestive system, they have only added a extra inclusive term for fatty liver, which is metabolic dysfunction associated with steatic liver disease. And the same they have done with the non-alcoholic steatic hepatitis. They have added the metabolic dysfunction of associated steatohepatitis. So this is the only change with respiratory and digestion. And this is skin and subcutaneous chapter. And if you remember, which is the chapter most impacted after our injury poisoning is with 116 changes, skin and subcutaneous was the huge change. But as I told, as I told that this not to be daunted and intimidated by 487 changes. This is all about laterality and new sites being added. So that is so evident with the description what I have included here. So the flank is a new site which has been introduced in most of the chapters. And when flank is introduced to skin and subcutaneous, you can imagine how many codes it can give us. So that is why we have so many inclusions, 116 codes included in skin and subcutaneous tissues, because new anatomical site is introduced and laterality is introduced and level is introduced. So that is the reason we have a huge change with skin and subcutaneous tissue. And especially with the non-pressure chronic ulcer codes, we see 150 new codes. Can you imagine 150 new codes have been included in non-pressure chronic ulcer codes, because this has been included with the new anatomical regions like abdomen, chest, neck, face, groin, upper arm, forearm, head, etc., etc. With laterality, severity, and all its unspecificity, the estimated total is 150 plus codes being impacted with this changes. And as I specified, flank is an important inclusion in the site, which we see in skin and subcutaneous tissue, which has been revised wherever the back abscess and back related injuries are there. We see the flank being included. So for audit sensitivity, I highlight as flank has been added. Flank is a region between the lateral aspect of thorax, between the rib cage and the iliac bone of the hip, and new codes are added to show conditions of the flanks throughout the chapters I'm telling you. So please be informed that you see a flank tenderness or flank injury, don't default it to back, because we used to do it like back, but not necessary anymore. We have a specific code to properly code it to flank. So 116 codes we have just finished in a few minutes now, because you understand what I say, not to be intimidated with the changes and the number which I have presented at the initial slide. And coming to the diseases of musculoskeletal and connective tissue, again, they have re-emphasized on the multiple sites, and which we have already learned, like specific site. If it is documented, please go with a specific site. If multiple site is being specified by the physician, go with the multiple site code don't go with other specified site. And the another addition is rheumatoid arthritis with abnormal antibodies is being included. This is a new category, guys. So in this, what happens is whenever there is an rheumatoid arthritis, in the same document, if you are finding a rheumatoid arthritis with abnormal antibodies, please ensure coding both. So the instruction is very clearly giving us a sequencing priority as well, where the code first rheumatoid arthritis is being specified. So please code rheumatoid arthritis first, but don't ignore coding the abnormal antibodies. Don't think that this is an integral part of the rheumatoid arthritis, because they give an opportunity by creating this code and clearly instructing us to code for abnormal antibodies. And this is again for a tracking purpose, because when I went back and read a little more about this rheumatoid arthritis, why is that a coder should capture this abnormal antibodies? They clearly state that there is a statistical purpose for scoring this abnormal antibodies. So ensure that both are coded. The abnormal antibodies of arthritis is not an integral part of rheumatoid arthritis. That's the catch here. And next one is arthropathy in blood disorders. Code first the disease, and arthropathy in blood disorder is a new category. Please be informed. Next is on the genitourinary system. A lot of genetical disorders are being included here. Immune complex, idiopathic immune complex, secondary immune complex. Please keep these terms in mind, because whenever you see this in your documents, ensure that you are being familiar with it, and explore further if you are finding any nephritis, especially glomerular nephritis and sclerosis, and ensure the nephropathy is coded appropriately. Immune complex, idiopathic immune complex, secondary immune complex. And coming to the name of the condition, proliferative glomerular nephritis, that is MPGN, which has been expanded, as I told, with the genetical impact to immune complex, idiopathic immune complex, and secondary immune complex. The same thing had happened with nephrotic syndrome and hereditary nephropathy with the APOL1 mediated kidney disease. So these all are the genetical impacts on the genitourinary system. Pretty much this is what we have with the genitourinary system. We don't have any changes with a pregnancy chapter, and we have one change with perinatal period chapter, that is about the P096. There is no code change though. There is no new codes, no deletions, but one change is on the revision of the instruction. So earlier, whoever have coded for prenatal would relate to this, that whenever we see abnormal findings on neonatal screening, we used to default it to the neonatal hearing loss. So we used to default it to unspecified or other specified abnormality of perinatal or a baby chart. But they have revised it and deleted the hearing loss, which was clinging in with the P096, and they have kept it very clear, abnormal findings on neonatal hearing screening. So this is a change which has been included. And the next chapter is a congenital malformation. As usual, a couple of very interesting syndromes being included. So on the pronunciation front, I am telling about the interesting fact about the syndromes. Every year we have some tongue twisters in the syndromes, and the same have done this 2026 as well. So we have Howe Foundation syndrome, CTNNB1 syndrome, Kabuki syndrome, and other congenital malformation syndrome. So these are the new congenital disorders. please get familiar with it. And also I want you to take a note about the use additional codes which comes along with the syndromes. So you see that autism, cerebral palsies, and congenital heart defects being included along with these syndromes. And Usher syndrome is not new for us, but what is new is the expansion. There is a subtype now added to Usher syndrome. In Usher syndrome, type 1, type 2, type 3 is being added. And in type 1, type 2, type 3, 4 and unspecified. What is new about this is on how much the patient is impacted. So the patient have deafness and balance issues at birth. It is type 1, and hearing loss at birth and balance and progression to vision loss, then type 2. And if having a progressive hearing and vision loss in teens and midlife, then type 3. And use additional codes for auditory and visual manifestation. I'm very sure you already know how to code the additional codes now. So one more important thing when I am talking about these types, don't take further with the availability of hearing loss with type 2. The physician should mention Usher as type 1, type 2, type 3. The coders need not take the effort to classify it by seeing the symptoms. Ensure we are still following the documentation appropriately and coding according to the documentation. This extra understanding gives us this extra understanding on the disease definitely gives us an fluidity while we are marching towards the documentation and evaluating the documentation. So just added all this type informations here. And the next one is symptoms, signs, abnormal clinical and laboratory findings. This also is a highly impacted chapter with additions. Again, not a very informative and very daunting changes. It comes with the added sites, laterality, and especially abdomen, pelvic, and flank again. Flank pain expansions in the sign and symptom. So that have contributed to the high changes in symptom, sign, abnormal clinical and laboratory finding chapter. And one thing I want you all to take a note is on the costovertebral angle tenderness. This is a nice inclusion with the laterality. This is a new inclusion. We didn't have a costovertebral angle tenderness before, but we do see the document specifying this condition. So now we have code for that specificity. And cannabis hyperemesis syndrome, we do have a new code, R1116. Please get familiar with these terms, which are new. Cannabis hyperemesis syndrome. And this is very interesting. Female genital cytology also got a syndrome when we find a abnormal genital cytology which is performed on a female. We have a code R87619, unspecified abnormal cytological findings in cervix. That is a very good inclusion. From the pathology point of view, this is definitely a very important change. Another one is on immunology findings. We can see that abnormal rheumatoid factors and anti-CCT without rheumatoid arthritis, there is a code now, that is R7681. This immunology findings are 76 series. If you go and examine, this will be a very important change. And this excludes one note is a very interesting one, which will remind us M05. Right, just now we have spoken about the M05. Okay, we'll go to the urine findings. And this also, again, will ensure that we are remembering our previous slides. Hyperoxaluria. When we have primary and secondary, we understood in the chapter genitourinary. But if the specificity is not available, then it defaults to R82992, hyperoxaluria. So this is a nice addition. And fecal incontinency subtype. This also is an interesting one. Before we had code for constipation and fecal impaction, there was no code for incomplete defecation. And you all will agree with me, there is incomplete defecation in any digestive system kind of, uh, 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 abnormalities. We see that incomplete defecation is a reason for admission. And so this edition of code is a very good inclusion as well. So, but it is very impact. So, so that's about symptoms. Hugely impacted now, sir. So we were talking about the sign and symptoms. Have been impacted with the addition of sites and laterality. Most of the changes in the sign and symptoms had happened due to abdominal, pelvic, and flank pains. And most of our changes seen because of the laterality and new additions of the sites. And one interesting code which has been added, which was not there, is costovertebral angle tenderness. We generally see this document available whenever we have a patient admitted, costovertebral angle tenderness, to specify very clearly the site. Now we do have codes to describe it. And the next one is cannabis hyperemesis syndrome, which is also a wonderful inclusion. And the next one is female genital cytology, and which is the abnormal cytological findings alone should be coded are 87.619. And when it comes to immunological findings, we have abnormal rheumatoid factor and anti-CCT without rheumatoid arthritis. Immunofinding code as a symptom are 7681. And now in excludes one, you will know why we have M05. Just a few slides before we have spoken about rheumatoid arthritis and antibodies. So we should not code rheumatoid arthritis and rheumatoid impacting antibodies along with the abnormal rheumatoid factors. So there is a huge meaning in why it is getting excluded. And when it comes to urine findings, hyperoxaluria, I think you all are recollecting hyperoxaluria when we had a good discussion about when we were discussing about the genitourinary chapter, we spoke more about hyperoxaluria. So hyperoxaluria primary and secondary you will be able to recollect. And when it is not been specified, that is when we have to code R82992, that is an symptom of urine findings, hyperoxaluria. And when it comes to fecal incontinency subtype, there is a code included, and for incomplete defecation. You all will be agreeing with me, this is a very important code because we definitely see in digestive related diseases this incomplete defecation documented. And there is a huge meaning for excluding with constipation and fecal impaction. Definitely it is excluded. We'll go to the next chapter where the highest changes were seen. But as I told initially, you can correlate now with this one slide, which is going to explain the entire changes of 116. So injury, poisoning, and certain other external causes changes. A lot of codes been added due to the flank injury, which got expanded with abrasion, blister, bite, foreign body, insect bite, unspecified, and a whole lot been changed with the inclusion of this one site. So that is the reason we have a huge change with the injury poisoning. And the open wound is being expanded with the peritoneal penetration, and which is no penetration, and with penetration there are two expansions happened with the open wound. And the neck fracture clarification, this is a funny change. So when neck fracture clarification, what is the change here they are talking about is, earlier if you go to neck fracture and see below neck fracture in the tabular list, you will find only the sites being specified: hyoid, larynx, thyroid, trachea. Now they have included it saying that fracture of hyoid, fracture of larynx, fracture of thyroid. And so that minor change also is a change for us. So that is been included with a neck fracture. And wrist and hand fracture, along with its laterality, is now being changed to only hand. Wrist and hand fracture is changed to only hand. They removed the word wrist from that tabular list. And when it comes to poisoning and drugs, there is two important drugs we have to become familiar with. That is fluoroquinone toxicity and xylazine toxicity. So these are the two toxicities which are introduced with 2026. And when we see what is fluoroquinolone and xylazine, these two drugs are lethal drugs, which can cause first one, fluoro, can cause a D difficile and Stevens Johnson syndrome and liver injuries and aortic ruptures. And xylazine is a veterinarian medication and which causes the toxic effects in the human, even death and necrotic wounds is what is very specifically which identified in some researches. So again, these have been classified poisoning, accidental, self harm, assault, undetermined, and it had further expanded the count of the codes included into this chapter. And interesting inclusions was on the war threat, theater effect, and a specific code for Gulf War illness and other war theater effects. So this is an inclusion. And when it comes to food allergic specificity, milk and baked eggs, I wanted to specify this word baked because the leading also I checked and it is very clearly leading with baked eggs. So they wanted to classify it separately for raw egg and a baked egg. So please be cautious with your document that there is a specific code for baked egg. And when you see a food allergy, and please accordingly code from the chapter 19. And this is the external cause of morbidity. And a few inclusions with the external causes of morbidity, we see that first one is foreign body injuries. Two things have been included in foreign body injuries. The first one is sharp objects into the natural orifices like nose, mouth. Natural orifices, sharp objects like glass pieces, pins or something. So the foreign body injuries, there is one inclusion. Another inclusion is fishing hook entering through skin. That also we have a new code introduced. External cause is every time interesting to code. You see a lot of activity and intent happening there. So fishing hook is a new inclusion and sharp objects is a new inclusion. And military operations, a blast overpressure in military, there is a new inclusion on Y37 series. And similar one is seen in Y36 also. And before that, activity coding expansion, two activities are being included. That is splitting wood and outdoor activity. There is an other specified outdoor activity code which has been included. And when it comes to blast overpressure injuries, war operations and war military operations is separate now. So Y37 is different and Y36 is different, but both have low level and high level blast overpressure seen as separate code. What is high blast and low blast? When we go and look into it, it means the patient being near the blast or a little further. And low blast overpressure is caused by largely caliber weapons and breaching charges. So this is all about the external cause morbidities. Very happy to see that only few changes are there in the external causes because all these years we saw tons of changes with the external causes of morbidity. And coming to the last chapter, factors influencing health statuses, we see new codes in the genetic susceptibility diseases, that is Z15, encounter for prophylactic surgeries and problem related to employment and unemployment and problem related to housing, economical circumstances, other contact with and exposure hazardous to health, And family and personal history of malignancy in situ, neoplasm, fallopian tubules. We see tons of change in the family and personal history of malignancy. You can see the series being listed here. And family history disorders of kidney and ureter, exposure to diethyl stilbestrol, that is DES, and personal risk factor due to exposure also has been added. And as I've been specifying, allergy to milk products and big dicks is been included. So when we talk about the audit sensitivity highlights about these factors influencing health status, I wanted to emphasize on the genetic related testings and genetic related conditions. All through the chapters, they have emphasized, maybe because of the evolution happening in the genetical industry and that stream of line. I think genetical testing also gains so much of importance when it is coded in the factor influencing health status. So please ensure that the related conditions are also appropriately coded, understanding the conventions which are being provided in each codes. And ensure that the documentation of this employment, unemployment, housing, and economic circumstances are coded appropriately. I really wanted to emphasize this point again and again because of the importance SDOH is being social determination codes are gaining now in all the industries, and a lot of grants and policies definitely influence the gain and loss of the patient. So ensure that we are all understanding the impacts and coding the hardships and employ, unemploy, and housing and economic circumstances with a complete attention to the document. Though it is not a condition or a disease, but it has a high value to be scored appropriately because it will definitely influence the grants, whether it is reaching the patient appropriately or not. And as I was specifying all this while about the baked, and this is very important takeaway that eggs are having codes now with the raw or baked. So this brings to the next slide, very important guideline change we have on the prophylactic organ removal. But what is the change? There is no change with you, with us coding the encounter for prophylactic surgery that stays as Z40. But what is important change here is, if applicable, assign the additional to identify any associated risk factors. This gains the importance with this change. So whenever we see a risk factor related to the malignancy neoplasm, please ensure that is being captured accordingly. So prophylactic organ removals should have the prophylactic susceptibilities and reasoning. So for example, here I have written a few genetical susceptibility like Z15 can be a high risk, which is documented in your chart, and Z80 to 84 family history and Z85 to 87 personal history. So please be cautious to quote the high risk factors along with the prophylactic organ removal. So coders must differentiate between genetical, familial and risk versus opportunistic removals. And if documented, please ensure you're coding all the risk factors appropriately. And whenever there is a prophylactic procedure documented, please ensure in all the categories you can code, and this will definitely have a very important while coding your code. This gives an added information about the patient. And this brings to the end of our session. Yes, we did it, all the chapters, and whatever didn't have much impact, we ignored, and we have completed all the 21 chapters. Thank you very much. So over to you, sir.
Thank you, Kanchana. Thank you for the wonderful session and tons of information that you shared with us. I hope this will be very much useful for all our members. while they are preparing for their exams or in whenever the code set being updated here in Abu Dhabi. I hope this will be an useful information for all of them. We also will upload our this video in our local chapter YouTube page, so at any time our members can go and see the video. So because currently now we are following 2021 guideline, so whenever there is 2026 is being implemented, I hope this will be an useful video for all the members. They can go and they can explore the changes actually. And also I would like to appreciate that you have spent a lot of time in including the impact as well, so that this will be a huge difference, because whenever there is DRGs, I think the members can select the correct codes, so that better DRG also can be selected whenever any patient is being admitted for the inpatient treatment. Thank you, Kanchana. Before going to the Q&A session, I will switch on the mic for all the members, so that if anybody has questions, you can raise your hands. I will unmute your mic.